Respected teachers, dear colleagues, and my students, welcome you all to our today's session of Bangladesh Live of IPDI Cardiovascular Conference. I am Dr Mainul Mahmud, Assistant Professor, Department of Vascular Surgery, Bangabandhu Sheikh Mujib Medical University. Today, my topic is how to make vascular access for peripheral intervention. This session of endovascular intervention, step by step, it is formed in collaboration with IPDI Vascular Surgery. At first, what is our approach to be chosen? The most important maneuver for a successful vascular access occurs prior to the procedures, and that is choosing the puncture site. The optimal puncture site choice should provide a low risk of complication and reasonable proximity to the site of intended intervention. What are the sites of vascular access? The common sites are the femoral artery, radial artery, brachial artery, tibial arteries, popliteal artery, femoral vein, and internal jugular vein. Here is another slide where we discuss that femoral artery is usually punctured retrogradely, usually for aorta and its branches, and sometimes we use femoral artery for antegrade puncture in case of ipsilateral infrainguinal disease. There are some other approaches such as SFA puncture in case of ipsilateral SFA or antegrade punctures. And most of the other situations, the approaches are usually retrograde, like is for brachial artery, radial artery, or popliteal arteries. Our first concern is how to start our intervention. Our first tricks is to working forehand. The operator should work forehand whenever possible. In this example, a right-handed surgeon stands on the patient's right side to puncture either femoral artery, or in brachial puncture is also performed forehand. Now the techniques. There are several techniques such as clinically guided, ultrasonography guided, and radiology guided. Before starting the procedure, in case of obese patients, the abdominal penis can be taped up during the procedure for better exposure of the femoral artery. Now, usually, the puncture needles are, there are two types of puncture needles, single wall puncture needles and double wall puncture needles. Standard size of puncture needle is 18 gauge, and it is compatible with OT pipe guide wires. First, we identify the landmark for anatomical landmark for an arterial puncture, usually the clinical site, palpate the artery, and other anatomical landmarks such as iliac, anterior iliac spine, and pubic symphysis for our identification of femoral artery. So we call it as a clinical guided identification. Puncture guided with ultrasound. Nowadays, it is most common and favorite to the interventionist. Puncture guidance with ultrasounds. The tips and tricks for ultrasound guidance. The probe is covered with a sterile cover such as polythene, and the local anesthesia is given, and needle over mid common femoral artery at 30 to 45 degree angle, and anterior wall should be punctured. This is the picture of Seldinger, Stephen Seldinger, a Swedish radiologist who introduced the procedure in 1953, which is known as Seldinger's technique. Now, in Seldinger's technique, we usually guide wire is placed through an access needle, then the access track is dilated, and cannulation of the wire is done, and after that, the guide wire was removed. This is a pictorial showing the single wall puncture technique. The question is where we should puncture for femoral artery. And we, according to textbook and our clinical experiences, the puncture should be done against the femoral head in the mid CFA, common femoral artery, and proper angle of puncture is very much important. It is usually 30 to 45 degree, and more than that will invite a lot of complications. Complications start with a faulty puncture, which may cause dissection. It also causes groin hematoma. The precaution of groin hematoma is a puncture over the common femoral artery. There may be pulsatile groin swelling, which is known as the pseudoaneurysms. The other technique recently is very much favorite to the intervention, which is the micropuncture technique, which is a micropuncture technique includes a 21 gauge needle, a 018 floppy tip guide wire, a 4 French short catheter with an inner 3 French stroker to slide over the low profile guide wires. There is a solution of difficult common femoral artery excesses. In obese patient, bony landmark and fluoroscopy can save us to a successful intervention. Percutaneous integrate puncture of the femoral artery. Here is a pictorial to showing that. For puncture of a pulseless femoral artery, with the help of a duplex probe, sometimes calcified common femoral artery is palpable in thin patients. And previous arteriogram of the location of the femoral artery in relative to the femoral head, it is also a procedure to identify the femoral head for puncture. And fluoroscopy guided accesses, there are first we have to palpate for anatomical landmarks, then perform the fluoroscopy. After that, the oblique projection of to see if the longitudinal image of the common femoral artery moves with in respect to the femoral head, anesthetize the skin, and then roadmap technique. Here is a pictorial showing the roadmap techniques. A picture for percutaneous puncture of the brachial artery. And at last, my tribute to Antyllus, a great Greek surgeon who lived in the 2nd century in Rome. She is most notable for the method of treatment of aneurysm. He died very early at the age of 17. My sincere thanks to all who are present here for their patient sharing. Thank you all.
So this is about the puncture. Step by step, first step is this is the opening door of endovascular procedure, and he has described. We have got here different size needle. That is the 18 size, 20, 21 size wire, and hardwares also in our. If anyone is interested, they can see, or we can show you at the end of the session. If any question from the audience, already we have started 15 minutes later. We expect questions from the audience.
Any questions from audience?